we have a very distinguished speaker who has, I feel very grateful to him and the other speakers that have come with him for his generosity in being willing to travel all the way from Bradenton to see you and speak to you today about the profession of osteopathic medicine. He is an associate director, associate dean for academic affairs at LECOM Bradenton. We have discussed LECOM in the previous class, so you are more or less aware of what osteopathic medicine is all about, and you know how much I support that profession because of the tremendous approach that they have for the treatment of patients. So with that being said, I would like to introduce Dr. Mark Kaufman today, and I would like to also welcome our former student who is now a first-year medical student in that institution, Rita Rasul, who was sitting right with you. She was a PA, she was a TA just before she left. So she's another one of our TAs who have accomplished their goals, career goals. So please help me welcome Dr. Kaufman, and as well as Rita to class today.
Thank you. How's it going? Too loud? Thank you for having us. We're very excited to be here. It's about 2.5 hours from here down in the Bradenton area, Florida, Lake Erie College of Osteopathic Medicine. I'm going to do a little bit of a presentation about that today, but the talk really about, I know what you're here for, is professions in the health services, so to talk to you generally about osteopathic medicine, what that means. You already recognized and welcomed Rita back. I have Dr. Jonathan Kaufman with me as well. We're not related. He's got more hair. He's got that hair thing. I was really interested in your clock here, and it must be very frustrating for you to sit through an hour and 15 minutes with the clock never moving. That was very interesting to me. But then I remembered, and I was told everybody has cell phones anyhow, so you're not paying attention to the clock. You're good to go. All right, first slide then, please. Oh yes, I'm a storyteller. I like to teach through stories. This is what you look like at the end of your studies for medical school. That's all you do. You study all the time. I am the longest, a little bit of introduction, I'm the longest matriculating student ever at LECOM. I started there in 1996, and I never left. I'm a slow learner. That's not exactly true. But I've been there in some capacity, starting as a student and graduating, doing a family medicine residency in the hospital of Lyon, and then working in the evenings as I was working at the VA, internal medicine, family medicine, board certified. And then coming back and teaching full-time, going through the faculty ranks, and then becoming an administrator. And I really like to tell that story because it's all the levels of medical school, from being a student to being an administrator, so I can share stories based on all that. Next slide, please. So when you are young, and you're thinking about what you want to do, my father told me that he was very surprised that as a child, the first time he ever asked me, so what do you want to be when you grow up? I said a physician, and I never varied. I never changed that. It was built into my DNA. When I see somebody bleeding, I feel empathy for them, but I also want to know why they're bleeding and how to fix it. My patient, unfortunately, look how sick he is. I think I might have killed my first patient, which is probably a bad thing. A friend of mine, one time we found bones from a dead frog, and Florida doesn't have them, but we have basements in Florida, in Pennsylvania. But found a dead frog in a window well. The next day I came back to him with those bones put back together and the skeleton of the frog. So some of you have that inside of you. You know. It sounds trite when you go out and you do your medical interviews. They always ask you, why do you want to go to medical school? Why don't you be a doctor? It's a real answer. It's a serious answer. I want to help other people. So it's built into your DNA. That's what you're destined to do. Okay? Where I come from, South Central Pennsylvania, a little place called South Mountain. Most people didn't go to college. We had 2 stop signs, 2 churches, and 2 bars to complement the churches. So, to think I could go to medical school was unheard of, and I had a lot of self-doubt. Did not think that I would ever meet the quality. I thought you had to be a genius, hence Albert Einstein on the slide, to go to medical school. And that's not true. What you have to do is work harder. You have to work harder than you've ever worked in your life, but you don't have to be a genius to do that and be successful. Because I had that self-doubt, what I was afraid of, next slide please, was that I heard other people going to pre-med and they study biology or chemistry or biochemistry, as this slide shows you, and then they aren't successful in becoming or getting into medical schools. So that then what do they fall back on? Next slide, please. And a lot of times that's teaching, and I didn't want to be a teacher. I wanted to be a physician or be in the medical practice. So my father is a military career guy, and it's kind of fun to talk to a class that's still trying to explore where they want to go. Being in the military, physician assistants, mid-level practitioners developed in the military. That's where they first started. So he said, hey, have you ever heard about this physician assistant degree? And I said, no. So he showed me what it was. I went, did a little exploring, found out there was a college not too far away from my house, about 2.5 hours. It's St. Francis, Pennsylvania. Anybody familiar with Pennsylvania? The state up north. So I went to the program so that if I was unsuccessful to go to medical school, then I could still be in medicine, because that was what I loved most. I wanted to be in medicine and practice medicine. So I became a physician assistant first. I practiced for 6 years in pediatric transplant surgery at Children's Hospital of Pittsburgh. We had transplant surgeons, fellows who came in from all over the world to learn how to do transplant surgery, and I taught them. So that was a great introduction while I was still going to medical school. I didn't realize the first day at PA school at St. Francis University, when they said, where do you see yourself 10 years from now? And I said, probably by that time I'll be done with medical school. Why are you here? Why are you using this as a bridge? And again, I showed you why I was using the bridge, because I didn't know if I would ever get it. Next slide, please. So the funny thing is, well, that's Children's Hospital now where I worked, and I worked at that for 6 years. And then, I was successful in my application and went to LECOM Erie, which is, I was the fourth matriculated class, so it was very new to our institution. Now we've been around for 26 years. And the interesting thing was that, remember I said I didn't want to I was concerned that I would not get into medical school, but once I did and I started teaching, I came full circle, and I love to teach. I love to pass on the knowledge to the future physicians. So it was a very ironic way it came about that I found out that what my true love is teaching. Actually, I do love practicing medicine. I love treating patients and have that satisfaction of the patients coming back to you and saving patients for people's lives. But even better for me is teaching Rita how to do it, because then I've impacted so many more people. I can have a patient panel of 2,000 patients, but if I teach 10 Ritas to treat 2,000 patients each, you can see that linear progression. So I am a teacher. That's my favorite thing to do. Next slide. So let's talk about medical careers. Medicine is a team. There's all kinds of careers in medicine, mid-level practitioners, through assistants, through physicians, and different types of physicians. So today I'm trying to tell you about osteopathy. Next slide, please. Andrew Taylor Still. He is the father of osteopathy. And how many people are familiar with him? Nobody. Oh, one. There you go. You're in. Send me your name. Admitted you didn't. He is an MD, or he was an MD. And in the late 1800s, when a episode of meningitis swept through his town, he lost his wife and 4 children to meningitis. They all died. He said there's something wrong with the practice of medicine. And at that time, they were still using arsenic compounds. And believe it or not, they were still doing some bloodletting. So he said something else has to be going on here, structure and function. So he dedicated the rest of his life to looking at the inner workings between structure of the body and the function of the body. He was, now we use, for lack of a better word, orthodox. He thought everything could be treated by manipulation. We all know that that's not true. When your appendix needs to be taken out because it's ruptured, I can't manipulate you. You're going to die. So, and that's important to know, that our graduates do everything. They do neurosurgery, they do family medicine, they do OBGYN. You can't name a specialty that osteopathic students and graduates don't do. There are 2 licensed physicians in the country at SLAC. I'm not telling that we are fully licensed to do any specialty practice at all. Interestingly, just to take a sidestep off, I know you're going to have a presentation later about chiropractic medicine. In Dr. Still's first classes, there was a student who came in and only stayed with him for 1 year and looked at only the manipulation component of it, and then started the schools of chiropractic medicine. So he is the father of multiple medical professions. He was an MD, he started the DO practice, or the DO profession, and by a student of his leaving to do the chiropractic profession, he started that as well. So now you have to participate. Tell me what the difference between an MD and a DO is. Sir? The title, there you go. So one has the DO behind it, and one has an MD, Doctor of Osteopathic Medicine and Medical Doctor. Excellent. What else? Yeah, so that's a component. That's definitely something. Now, a lot of allopathic physicians are seeing the utility of manipulation and picking up classes afterwards. It's not built into allopathic curriculum yet, but we get about 400 hours of manipulation. I think I'm supposed to stand over here. I keep walking back and forth. So we get about 400 hours of manipulation. I'm going to tell you some stories about that. It's going to get fun real soon. We're going to start talking about real life instances. What else? What else have you heard is the difference? The DOs are more holistic. They have a more holistic approach. So part of our tenets are mind, body, and spirit. Kind of a sad thing to say, though, right? We are known for that, but that should be every physician, right? And it is. It's just that our curriculum actually focuses on it. We bring it into our curriculum. We assess our students significantly on their bedside manner. You know, you have a lady, 64-year-old lady comes in, she's complaining of fatigue, and you take a history from her, and you get down to the social history and say, do you work? And she says, no, I don't work. I have 3 children, and they bring over their children after school every day. They come to my house until their parents get off work, so I take care of 7 grandchildren after work every day. And the next question out of your mouth is, what medications are you on? Seriously? I think you just missed a very critical component of why she's tired. She's busy, that's why she's tired. She's taking care of a lot of kids. So yeah, we focus on how to ask those additional questions that make it. I'm not just treating you, I'm not treating a diagnosis, I'm not just a mechanic of the body, I'm a mechanic of the spirit as well. So, a couple stories for you, go ahead. Oh, actually, first, licensed physicians, go ahead and hit the next button there. Doctors of osteopathic medicine and medical doctors are only 2 fully licensed physicians in the country. We treat with medications, we treat with surgery, we treat with our hands, and the curriculum is very, very similar. Go ahead, next click, actually. So here's how you get there. Next click. 4 years of undergraduate study, pre-med, most of it science-based. Now, do all people who go to medical school do strictly a science-based? No. And literature will actually show you that those people who do the other non-traditional, non-science backgrounds, they still have to take the prerequisites to get in, so it's a minimal amount of their curriculum, but they do just as well. And when I say just as well, maybe a point or 2 off percentile-wise, but they are very successful medical school once they know what they do. So the basis of pre-medicine being in science is not necessarily the only thing that you have to do. The summative assessment is all of you are working so hard to study, or going to be working so hard to study for one big test, right? The MCAT. Golden ticket to get into medical school. Well, guess what? To speak about LECOM specifically, I started a program where physician assistants could come back to medical school and do it in 3 years instead of 4. And a lot of them have been out in clinical practice for 10 years. And I had to go to them and tell them, you need to take the MCAT. And you need to take an organic chemistry. Yeah, that's hard. They've been in practice for 10 years. Why do they want to go back and do that? We know, and I'm sorry to tell you this, but we don't use that in medicine. Physics? How many of you got to take physics? Yeah, everybody. I can tell you when I give somebody a new high blood pressure pill, or blood pressure pill, hydrochlorothiazide, or whatever it is for their hypertension, I do not calculate the degree of resistance of a red blood cell as it travels down the tube of their arteries. I don't. So yeah, you learn that, but we don't use it in the practice of medicine. So I'm transparent. I used to tell everybody I had a T tattoo on my chest for transparency. But I got called out on it one time. The very first question was, do you really have a T tattoo on your chest? Like, no. They go, well, there goes your credibility. I'm not asking you. Next slide. Then you do your 4 years of graduate study, 2 years didactic, first 2 years of medical school. And this isn't, some medical schools integrate clinical much earlier. They'll do a semester didactic, a semester clinical, semester didactic, a semester clinical. There's some integration. But generally, it's 2 years of didactic study and 2 years of clinical study and rotations. And then again, you take this huge summative assessment, the COMEX USA for the DOs, for the USMLE, for the MDs, and I'll say DOs. Last year's LECOMS class, 75% of them took the USMLE in addition to the COMEX. LECOM, because of that 3-year program I talked about for PAs, we recognize that it's not about the MCAT. And again, with transparency, maybe DO schools take criticism for that, because they can say they take Harvard's medical school class and can put all of the DOs that are successful at applying to LECOM at the bottom 20% of Harvard Medical School. What we don't do is just do grades. As you said, we treat patients holistically. We also look at our applicants holistically. It's not just about your MCAT. It is about your complete application, and are you a real life person? You can have a fantastic application didactically and not be a good physician, because it takes more than that. It takes that. It takes professionalism. My favorite applicant ever to medical school, guy was great. I don't know, he had 4.0 GPA. Every question, you couldn't even get the question out before he would start the answer. Like, where do you see myself in 5 years? And he tells you exactly. He knew every question that was going to be asked. So it was another professor here, and I was sitting at the head of the table. It came my turn to ask the question, and I looked up at him and said, "Do you believe in ghosts?" And the heads of the other 2 professors just snapped towards me, and I wouldn't look at him. And then they snapped back at the student. And he's like, yes. and then he told me why. For the next 5 minutes, he told me why he believed in ghosts. And again, with transparency, I said, "Oh, that's a great answer. Doesn't matter what your answer was. It wasn't a real question. I just wanted to see who you are. Thank you for now sharing with me who you are." Because he was just prepared. There was this facade there. Was he real or was he not? So, God is not the way. Only because he believed in ghosts. Next one. Then what do? After graduate? Well, you're going to do residency, 3 to 5 years typically. In 2020, single accreditation system. You probably don't know about this. I know you're mostly freshmen and sophomores here. There used to be 2 residency matches, allopathic, osteopathic. Now they're merged together. Everybody's going to be competing for 1 residency match. LECOM does extremely well. 100% match rate last year. Our students who come to LECOM stay at LECOM and do the residency. That will change under single accreditation, because we have a different competitive pool now. I don't know how far it's going to go, but we will do successfully well because our students are trained and do very well on their boards, which is the #1 thing that residencies look at. And then, of course, you have some of the assessment board certification by college. There's osteopathic board certification, allopathic board certification. There's both of them that exist to continue. Next slide. So, going back again to DO versus MD, there is a perception, again, transparency, if you look it up on Student Doctor Network. I read Student Doctor Network. It's not all true. I'm not going to answer those questions. There is a perception that MD is better than DO, is better than 4 medical school graduates in this country. That is changing. In 2020, 25%, 1 out of 4 medical school graduates will be DOs. So our growth is faster than allopathic programs, and we're narrowing the gap. And even though, again, the statistics say that if you look at allopathic schools, that MCAT is so much higher, we look at other things. And I'm an example of that. I was a non-traditional student, 6 years working in transplant surgery. My MCATs were at the top of the pyramid. 50% of people did better than me, 50% of people did worse than me. I did, as I said, I did transplant at Children's Hospital Pittsburgh. I had a letter of recommendation for University of Pittsburgh from Thomas Starzl, who is the father of liver transplantation in the United States. And I did not get an interview for the University of Pittsburgh. So I had a sidebar chat that they arranged for me to talk with a committee member, and they said they just wanted to know why I never took the MCAT again. I had been doing transplant surgery for 6 years, from harvest to assessment to ICU care to discharge. And if that wasn't important to my medical school that was going to look at me, I wasn't interested in going there either as a good match. Lecon looked at me and said, hey, something's going on here. I think this guy will do really well. And I did. Except it just took me so long training. Next. So, a couple stories for you. Okay, let's have some real fun now. You can't tell because of my suit, but I have chicken legs. And I never did downhill skiing. I don't know if I'm talking Florida crowd, you know what that is? That's snow. And I knew I would snap my leg in half and I would do a full rupture of my anterior cruciate ligament. So I never did downhill skiing. Instead, what did I do? Martial arts. And I black belted, and I was trying to show a yellow belt how to do a takedown. And he pinned my leg first and then tried to sweep it. And guess what? Total anterior cruciate ligament tear. So I was right. I knew I had a weakness there. And would it be a big deal? No, but my kids, my wife is an overachiever, by the way. She is a physician assistant and an attorney. She's such an overachiever that even my first semester of medical school, she had to have twins. She couldn't even have one kid at a time. She had to have twins. So my twins found out very quickly that when we were on vacation, if we were running along the beach and Dad was chasing them, all they had to do was make a really quick right-hand turn, and Dad would roll in the sand. It was so funny. Dad knows stability. So I thought, for quality of life, I think I'll get this ACL taken care of. So I went to the chair of the Cleveland Clinic orthopedic program. He's the guy that did the knees for the Browns. I know, that takes me around. Cavaliers and Indians. And I thought, if he can do the knees for these multi-million-dollar players, he can do my $1.95 one. No problem. I saw him for 3 visits. 5 minutes. And that's okay, because I wasn't there for his bedside manner, I was there for his surgical technique. Fantastic, by the way, job. Laparoscopic, I didn't even leave with a brace. It's a crazy thing. So, during the day of my surgery, I never said what my profession was, but the day of my surgery, the anesthesiologist came up to me and was telling me about how she was going to numb my leg. It was going to be dead. If I tried to stand on it, I would know I was standing on it, it wouldn't support my weight, and I would fall down and injure my new knee. I said one word that was not a lay term. It was something medical. I don't remember what that word was. And as soon as I said it, she said, "What do you do?" Doctor. Doctor what? I'm a family medicine doctor. Oh, okay. And then she left. 5 minutes later, the surgeon came back to me and pulled up a chair and sat down and talked to me for 15 minutes. Worse yet, when I woke up, my chart had been changed. In 900-point font, it said, Dr. Kaufman. Yeah, that's wrong. That's wrong. I never told him I was a doctor. I didn't want any special treatment. You should treat each patient the same way. And I'm not saying he's allopathic or osteopathic, but he did not have a holistic approach to his patient. He had a patient approach based on their status. Seriously? Really? That's a terrible thing. So unless you treat every patient like you would your own family member, if you like your family, then you're not doing a good job, right? That's one secret. Let me give you another. I'm rounding. It's a Friday morning. I'm attending. I have an osteopathic medical student with me on rotation. I'm looking at a new patient that came in overnight who was there for a rule-out heart attack again. Probably the 6th time. He had had 6 hospital admissions. He had had 5 stress tests. He had another stress test that was scheduled. He had already had a cardiac assessment with a needle that went up through his femoral artery and perfused his heart with cardiac catheterization. It's not a non-invasive procedure. He had echocardiograms. He had all the blood work. All negative, negative, negative. Because again, he had a rule-out heart attack. And I said to him, I looked at the clock. No time at all. And I said to the student, I said, something's wrong here. Anybody in here martial arts? Yeah, there you go. One of the first things that they teach us is a down block, right? Well, in a medical history, asking the first question is your down block. It's the very basic. We had to start over with this patient. I said to the student, there's something wrong here. This doesn't make any sense. So I went into the student, or into the patient, and I said, I introduced myself, of course, and said, see, you have the chest pain. When did this start? was one of the first questions I asked. And he said, 3 minutes ago. The next question I asked was, she's just starting her history of physical examination, and she's like, I don't know yet. So the next question was, what were you doing at the time? And he said, I was on a ladder working on my roof. The ladder started to slide. I took it down as far as I could, then I jumped off, hit my right side, and kind of collapsed on my right side. And the student and I looked at each other, because these are the stories that our attending or our teachers told us all the time. And I looked at him, he looked at me, and we're looking for the camera, because we think we're on candid cameras, can't be real, and now that somebody say that. You know, falling off ladder might have been scary, but it probably didn't cause a heart attack. It's probably musculoskeletal. So I asked him if he knew what an osteopathic physician was, and he did not know. Now remember where we're at. We're in the ICU. And he's got wires everywhere, and oxygen, everything's going on. So I said, look, your first workup is negative. Standard of care says what? We do serial cardiac proteins to see if there's injury to the heart. We do serial EKGs, serial blood work. If they're all negative, I'll be able to send you home this afternoon just to see what happens. But in the meantime, I'm an osteopathic physician. I told him about structure and function. Is it okay if I examine you and manipulate you? And this is what you were saying about part of the difference in the curriculum is you do manipulation. So I went downstairs and got a portable manipulation table, took it up to the ICU. He was messed up. So I started at the bottom, I worked my way up to the dominant, sacral torsion, rotation of the thoracic, lumbar spine. Here's what your body tries to do. Your eyes are supposed to be parallel to the ground. If you upstep on an nominant, then you have to rotate your sacrum, and then you do your thoracic, lumbar spine, you're like this. This is what you're working with. How comfortable is that? Trying to keep your eyes level. So I examined him, fixed him. 30 minutes later, I'm just guessing about how long it took. He stood up from the table, and he goes, first time in 3 months, I don't have any chest pain. Interesting. Standard of care says I'm going to do the lab work that I talked about, and see you this afternoon, if everything's okay, we'll let you go. Sure enough, afternoon rounds, everything was negative. So, all right, we're going to discharge you. This is going to come back, because this has been going on for 3 months. It's chronic now. So I'm going to call you Monday, and we'll get you back in for some more manipulation. So I called him Monday, and he said, hey, I really appreciate your calling. I said, yeah, when can we set up your appointment so I can do your manipulation? Just for what? I said, for your chest pain. Because I'm in chest pain. I said, all right, but it's going to come back. Because it's been there for 3 months, it's going to come back. So I called him about a week, 2 weeks later. He goes, you are a nice doctor. No doctor has ever called me twice. But you know what? I don't have any chest pain, thanks. I don't need an appointment. So think about that. I would not say it was overestimate to say $400,000, $500,000 were spent on that. And it took me 30 minutes of manipulation. When he stood up off that table, the student and I looked at each other, and when he said his chest pain was gone, we had to look again for that camera and say, really? This can't be true. Yep. And that's what you can do. And that is the power of manipulation of structure and function. So I want you to think about that. It is a tool that we have as osteopathic physicians that our allopathic brother do not have, or are now just learning to do. So I don't want you to think of osteopathic manipulation or osteopathic profession as a second choice. This is a profession, a fully licensed physician, that should be on your table to say, what kind of personality do you have? What kind of a person are you? Do you utilize a holistic approach to everything you do already? And maybe you ought to think about this as a first choice. Next slide. I'm done. So what we'll do is, I'm not going to answer questions right now. I'd like to give the perspective over to Rita, so she can tell you what her experience has been as a student, and then we'll come back to questions.
So, hello everyone, my name is Rita Rasul. I'm in my first semester of med school at WeCom in Bradenton, and I actually graduated from UCF just last spring, so it was not even a year ago that I was in your seats. And as Dr. Lopez said, I TA'd in this class for a year before I left, so I know exactly what you guys are going through. And while I was here, just a little bit of background, I was heavily involved in AMSA. So anyone in AMSA in here? Yes, my FAMSA's out there. I was very involved. I was a director. I went to Washington, D.C. with them for convention, so that was something I really loved. And just to touch more on what Dr. Kaufman talked about with the holistic approach, as soon as you get into WeCom, you're mainly in anatomy and OBP course. So OPP is Osteopathic Principles and Practices. Now, in that course, you learn everything that has to do with osteopathy. You learn about the techniques and the theories that go behind treating a patient and diagnosing a patient with osteopathy. So it's really in that course where I realized how much more I'm learning and beyond the core sciences that I'm learning than my MD friends are. Now, Dr. Lopez wanted me to touch on our problem-based learning curriculum, which is very different than any med school or DO school in general. And how that works is as soon as you get into LECOM, the whole class is put into groups of 8. Okay, so you have your problem-based learning groups, and all the learning occurs in a problem-based way. So that problem is a very well-constructed case, as Dr. Kaufman, among other administrators, write, and each case has a specific focus. So it could be a diabetes case or a lung function case, and you learn all the medicine as you go through the case to try to figure out what's wrong with the patient, and that's where all the learning occurs. Now, another cool thing about LECOM, it could be cool to you or not, but if you're that type of person, we don't learn through lectures. As soon as we start, we have anatomy and OPP, as I already mentioned, which are both lecture based. But with PBL, you learn a lot from textbooks versus being fed the information. Has anyone heard about this whole PBL process in LECOM at all? Dr. Lopez has talked about it. So yeah, that's how it works. And all the medicine is learned just like that. And that's why you hear that LECOM has class mandatory sessions 3 times a week for 2 hours each. Because in that session, we all have our textbook, our group of 8, our PBL groups, and according to what the case is, we look for that information in different textbooks, and we learn via that. And then we meet again, we talk about what we learned about, and then we look for more things to read. So that's how that works. And even within those PBL cases, as we move along, it takes about a week and a half, we come to a diagnosis and a treatment plan for that patient. So you learn about the pharmacology, the pathology, the anatomy, everything that goes into that case, and that's how you learn it. Opposed to being fed the information through lectures, where you're reading a chapter from page 1 to page 2, to page 100, I guess you could say, and there's no rhyme or reason to it. So that way, that's how PBL is different. And once you get to a treatment plan, going along with the whole holistic approach of treatment, we're also always asked what OMT, osteopathic manipulative techniques, you would use to treat the patient, if applicable. So that type of approach and philosophy is intercalated into everything that we do. Not only at LECOM, but it should be at every other DO school as well. Now, further, so what does the day in my life look like? Let's talk about that. I'm sure you guys want to know. Right now, we're mainly in anatomy and OPP, so we don't start PBL until a little bit later. So there's a little bit of a transition before you go into this whole new curriculum of learning from textbooks. So I'll wake up, we usually have lecture starting around 8:30, do my morning routine, go to lecture, which could last from 2 to 5 hours, and we have little breaks in between, and they're an hour each. And then after that, so remember we're all in those groups of 8, and depending on what your group number is, you have different classes throughout the day. So you could have, after that 5 hours of lecture, a big gap, which would be from 1 hour to 3 hours, and then you have anatomy lab right after that, which lasts for 2 hours. Then after that, you're done for the day as far as on-campus activities, for the first 3 months of class at least. And during that time, I usually have a break, a real break where I'm not on campus. I'll either work out or eat. I always eat, always work out. You study for a little bit and then you go to sleep pretty much. You have a little bit more free time and then you go to bed and you do it all over again. Now, you may see, according to undergrad, it seems like a lot of studying, and it definitely is. But you get used to it. For me, at least, I was born and raised in Orlando. I'm as native Floridian as it gets. So, and I went to undergrad here. My family lives here. So my weeks are very study focused, and then I go home on weekends actually. So because LECOM has this problem-based learning curriculum, and you're not in class 9 to 5 with the majority of med schools, DO or MD, you can really put your schedule how you want it. So that sounds really interesting looking into LECOM because it's very specific, and specifically the Bradenton campus. Now, so far, I've been liking med school very much. I'm doing well. As I said, anatomy is the first course. Have you, any of you guys taken Dr. Sanson's class yet? Planning to take? I know, it's brutal, but it pays off 100%. Like, if I see him today, I'm gonna just hail him because it's really good, it helps. I've been doing long classes. I really like how LECOM puts you into groups right from the beginning, because right off the bat, you have like a friend circle already. So it's like you're going to high school for the first time, or you're going to UCF for the first time. It's such a huge place. You already have a group set up. Our faculty so far have been great. Our administrators are awesome, as you can see, very approachable. And a full circle,
I didn't say it.
a full circle moment for me is when I was in AMSA, I actually toured LECOM as a sophomore in undergrad. And then, having only just learned about osteopathic medicine, like you guys all are, who's learning about osteopathic medicine for the first time in this class? That was me too. That was me too. This is where I learned about it for the first time. I went to tour LECOM. It's a very nice, clean place, a lot of palm trees everywhere. And I was like, okay, we'll see what happens in my junior year. I'm coming on to my senior year, okay, I took the MCAT, I applied, okay, and here I am in my first semester, coming back and teaching and talking to all of you guys about osteopathic medicine too, so it's a really meaningful thing, especially since I TA'd in here as well. I was a biomedical sciences major. I know our majority of you guys biomedical sciences, yes, okay. So, I'm still in the loop, I guess you could say. If you have any questions about classes or about LECOM, please feel free to ask me later on, but thanks for having me.
Thank you very much. I'll point out some curriculum differences. LECOM rate is PBL only. And the good thing, as Rita said about that, is once you start the cases, and we do start now first semester with a clinical approach. So instead of 2 years of didactic, which is not into a clinical setting, your PBL cases are, tell me the history. What brings you in today? When did it start? Have you ever had this before? What makes it better? What makes it worse? And then you ask about physical examination, even though you don't know how to do it yet. What parts of the physical examination should you look at? And which labs would you order? And that's where you build your differential diagnosis. So it's case-based from first semester on. In Erie, whereas the campus started in Erie, we have 5 learning pathways. Lecture discussion, that's what you're doing right now. Somebody stands in front of you and gives a presentation, oftentimes with PowerPoints, picking out the most important aspects or the hard concepts. And then you study on your own too, but it's a presentation kind of format. We have that in Erie, that's the majority of our students in Erie. Now we also have PBL in Erie. We have a directed study pathway, that's my wife I was telling you about. Here's the respiratory module, and there's 200 objectives. And then just get out of her way. That's all she needs. She's very, very good. She should be an osteopath because she can manipulate her way. There you go. Still away. Good. And then we have 3-2-3-year pathways. So if you know you want to do primary care, and some people do, like me, if it would have existed, I'm a dinosaur. They didn't have that pathway when I went through medical school. I knew I wanted to do family medicine because my mind jumps. I need to see a 2-year-old and a 92-year-old, and this person needs a driver's physical. This person needs some minor office surgery, and I can cut them. I love to cut people. It keeps me interested through the day. Instead of like, if I was a cardiologist, yeah, they're a specialist in their field, but they do the same thing all day long. Hypertension, high cholesterol, arrhythmia, hypertension, heart failure. Oh, yay, something new. So I couldn't do that. I'd be bored. And that's my personality, is that I have to jump around. So there's a 3-year pathway in Erie that allows you to go to medical school and do it in 3 years instead of 4 if you want to do internal medicine or family medicine. And then there's a 3-year pathway which none of you apply to because you're a PA first, and you come back and get your DO degree after 3 years instead of 4. So I think we're ready to answer any questions that you have about osteopathic medicine in general, our curriculum, LECOM, student experience, faculty experience, whatever you'd like to do. Yes. Well, I can't hear you. Sorry. Do we want to get one of those things? Can I take that back? So did everybody else.
So with the physician assistant route, are you taking classes that are doing that program in the hospital in your undergrad years? Like how do you combine the two and then still go to med school?
So actually, our PA to DO program, you already have to be a physician assistant. They come to us with their degree already. It was like me. I went to medical school or DO or PA school first, and knew I wanted to go back to medical school. So then those PAs who are certified by their boards get to come back and do it 3 years. And they do extremely well. Question? Sure.
Okay, so when you were talking about the patient with a recurrent heart problem, you mentioned there is a table that you utilize in order to manipulate him.
Yeah.
What does that consist of? Like, how does it?
It's just she asked about what kind of table it is. It's just a portable manipulation table or massage table. You can get on Amazon, Google. But he's in an ICU bed. And he has all these wires and things, so you can't manipulate very well on a bed that doesn't have a very strong support behind it. So we have these portable tables, and I carried it up in my office, because I would use it in my office as well for the outpatient people that came in. We brought that up.
Also, just to add to that, as a student, we practice on those tables as well. So we have an entire lab that's called the OMM Skills Lab, and they have those tables laid out like you would think in a cadaver lab. But we all practice on each other with the different techniques at least once a week.
Yell it, I can think of that.
So for the OTP classes, do you guys learn about the ORTs in there? Like
Yeah, so we do, actually, and the techniques are one thing, the actual manipulation, we call it OMM, osteopathic manipulation, or manual manipulation. And then there's OPP, which is osteopathic principles and practice. So the actual laying your hands on the patient, the OMM, are definitely techniques we do from first semester all the way through to the fourth semester when you go out on your clinical rotations. And it's literally every musculoskeletal component of the body that we learn. How we can do sacral or cranial techniques. Do you mind if I break into a story? I think we still have time. I had a nurse in the ER who, down there for a rotation, going through and admitting a patient, she said, I had this terrible headache. And there's a lot of osteopaths around, and they keep manipulating me, but the headache keeps coming back. And I said, well, what techniques are they using? Well, everything they were doing was at her neck and her head for her headache. And that's not the way you want to do it. If you have dysfunction, as I was telling you below, yeah, it can cause problems in the head, but you have to work your way up. So when I looked at her, that's what I started. I started with her ankles and worked my way up. And again, she had dysfunction at multiple levels. She had sacral torsion again, and anomalous changes, and thoracic lumbar, and cervical spine. The last thing I did is I worked my way up with her was a cranial technique. It was called cranial rhythmic impulse. And it's a fluctuation. You can feel that the skull is not as solid as you would think it is. It actually moves. And we can feel that. And I could feel her cranial rhythmic impulse. And this is the movement of cerebral spinal fluid through the cisterns of the brain. And I could feel that was off. And I was able to reset that cranial rhythmic impulse. And again, after about 30 minutes of treatment, she's had the same response and said, oh, the headache's gone out. She remembered she had it, and then she'd be treated, and the headache would go away for a while, but it would come back. But I saw her a week later, and yes, now the headache had gone away and did not come back. So that's what we do in the OMM lab, is learn everything, all the techniques from each joint system, but also the principles. And we have tenets in osteopathic medicine. Body, the structure and function are interrelated. And this is what Andrew Taylor Stoll started exploring. He had a patient that stuck in his mind that really started on it was an asthmatic patient. Of course, they didn't have all the medications that we have now for asthma. This is back in the late 1800s. But he noticed that she had dysfunction of her chest wall. There was asymmetry. And he was able to fix that. And when he fixed that, her asthma got better. And that was the aha moment. The light bulb moment was structure and function goes together. There's a lot of nerves that run along bone and arteries. If that bone is out of place and putting pressure on a nerve or an artery, you're going to have dysfunction. So to fix that allows the body to do another tenet in osteopathic medicine, is the body has an inherent ability to heal itself. Now that doesn't mean, as I was saying about appendicitis, that that's all we're going to do. We're going to say, no, I'm not going to take appendix out because we can manipulate this. No, we know standard of care. And there's no standard of care when somebody's having a heart attack that says that you should manipulate first. And we know put them on oxygen, we give them a beta blocker, we'll give them an aspirin, we'll get them to cath as soon as possible, get a bypass if we need to. So the standard of care stays there, but I can also manipulate at the same time. The vagus nerve innervates the heart. And if I manipulate the cervical spine so that it stimulates the vagus, it slows the heart rate down. Isn't that a problem if we're having not enough blood flow to the heart? That if it's squeezing faster, it needs more oxygen, right? So if you can slow the heart rate down, there's less of an oxygen demand. There's less injury that's going to occur. So I add it into my treatment. It's not my only treatment. But as the stories that I told you, sometimes you can manipulate and that's the only thing that you need. Yes? Are you allowed to work while you're a medical student? Oh, are you allowed to work? Okay, so what, now, this is the question, I understood. So why are you going to medical school, can you work? No, yeah, no, maybe. So here's the thing. Undergraduate is, and correct me if I'm wrong, but I remember my undergraduate, Monday, Wednesday, Friday, 3 classes. Tuesday, Thursday, 2 classes in the lab. Medical school is 4 times that amount. First semester is purely learning how to survive, correct me if I'm wrong. You need to know, it's not complex material, it's voluminous material. Nothing you've ever experienced before. So I told you about these PAs that come back to medical school. They think they know a lot. I was a PA. They think they know a lot. They think they can sit and take our boards, which they can't. I tell them to buckle their seatbelts because as much advantage as they have of being a PA, it's going to help them. But if they don't take it seriously, they'll go down. I tell them, do not work in your first semester at all. Do not participate in research in your first semester at all. Time management is what you learn. And you learn how to handle that volume. Then in your second semester, maybe a couple hours here and there, maybe a little bit of research, but that's it. Like 4, 8 hours a month. That's the volume of medical school. That's the major difference. Great question. Other questions?
I have something to add to that. I told you guys how involved I was in AMSA to the point of being in leadership and even traveling with them to Washington DC and everything. I have yet to be that involved in a club so far, and I've been in medical school for about 3.5 months. And I was talking to Dr. Kaufman on the way here about, what's my next step? What do I need to do? And he said the exact same thing that he just told you guys. You have to get used to the load first. I did well in undergrad. I'm in med school now. So you go into med school thinking the academic's not going to be that hard. It's just going to be the load again, and that's what it is you have to get used to. Here, your PowerPoints are how big. I took Dr. Borgon's classes and everything. They're what? We have an example. How big are they? How many slides? Like 60 is like huge. We have like 150 in 2 hours, in 1.5 hours. So it's just getting used to the load. When you look at the material, it's not that hard. Okay, this is what it is this. You have these pressures, but just learning it that fast, so you have to get used to that. You have a question?
To get into PA school? Position, how much research? Yeah, it's been a long time since I applied. 86. My wife happens to be the chair of the physician assistant program for Gannett University outside of Ruskin program, outside of Ruskin. They do require shadowing. They would like to see a little bit of undergraduate research, but it's not highly weighted in their application. What they're really looking for also is the ability to handle both curriculum and outside experiences too. Again, a holistic approach for the PA programs too. So if you did a little bit of research in undergraduate, research assistant or at least participated in some projects, community service, and good didactics. Believe it or not, her class for PA, for the graduate, if you're not going in to do undergraduate 5 years altogether, you're just going to the graduate part, they have like a GPA of 3.9 is their average accepted student. Now they only have 40 seats. We have 196 seats, but our average GPA is 3.5. So that's actually harder to get into PA school than it is in medical school. So, hope that answers your question. Yes?
I actually have a question for Rita.
Sure.
So you said you were heavily involved in AMSA. When in your undergraduate career did you make that switch or realize that you were really interested in osteopathic? And did you do track inside of your biomedical major and how did that translate to osteopathic?
Did you do a track? What do you mean do a track?
Like, that was like the neuroscience track.
Oh.
Cell biology.
Okay, yeah. So even though it was only a couple of months before I left UCF, I graduated spring 2018, we didn't have tracks. We just had a pre-professional track, which was pretty much the only difference was this class requirement and maybe one other thing. But I knew I wanted to be a doctor when I entered UCF. So I wanted to know what would get me to that path, and all the club that everyone was talking about was AMSA. I did go to SOMA, I was on the email list and everything, I went to, International Medical Outreach Club and everything, but I just liked AMSA because the people in it, the events they had going on, it wasn't that I was MD first and then switched over to DO, but it was really in this class, which I took during my second semester at UCF, that I learned about osteopathic medicine. I still continued with AMSA then because I already had so many friends in it, and I was getting my volunteering, I was getting research opportunities, I found a mentor to shadow through that club. So it wasn't really MD versus DO, it was just I like that club.
Any other questions?
Yes. The question was, do we use other, is there a curriculum built in that has other pathways like acupuncture, acupressure, herbal medication? We touched on it a little bit. It's not on our boards, and that's an unfortunate thing in medicine, is do you teach towards the boards? There's just so much material that we can't add in curriculum all the time without taking something away. So we don't put it into the curriculum as a requirement, but the clubs do a lot of that. We'll have somebody come in that does acupuncture in the clubs, or somebody has an interest in doing some other part of alternative medicine, treatment, holistics, the herbals, the essential oils, then it comes in through that way, but it's not built in, much of it is not built into the curriculum, so. Too much to do. Yes, sir.
How often do you have lecture and problem-based learning?
The question was, how often do you have lecture and problem-based learning? So to get you started off, anatomy in the first semester, starting in the end of July and going through now, is lecture-based. So the first 3 months is heavily lecture, and then you transition into PBL and almost all the lectures. That's not true. We still have OMM, which has a lecture, and then most a lab. So if you're spending an hour in a lecture, you're spending a couple hours in the lab each week. Same thing with history and physical examination. Hour of lecture, but then mostly in the lab. It's a hands-on approach to those. So very little lecture after the first semester. And we have mini courses that will throw in here and there that are lecture-based, maybe ethics and medicine, or other things, smaller curriculums like that. Geriatrics as a distant education, supplementary lecture.
And an easy way that I look at it is, every course we take is lecture-based except the problem-based learning, which is where a lot of you learn a lot of the core sciences. As soon as you get in, again, anatomy is lecture-based, all the mini courses are lecture-based, and then everything pretty much has a lab component except if you're taking a course on ethics or medical law, for example. So OMM, the course is called OPT. You have a lecture section and then a lab section, which goes for the whole 2 years. Everything is lecture except the main thing is PBL, and that meets 3 times a week for 2 hours each.
I think a fair number might be, after anatomy, there were about 80, 85% PBL, 15 to 20% lecture.
Yes, yeah, even though those little mini courses are lecture-based, the big chunk of where all the learning happens, a lot of the learning is PBL, so it's that problem-based learning curriculum.
For those of you who have additional questions, you can come down after class and talk to our wonderful speaker. Please help me, you can thank the registrar.